everybody, and welcome to another session from this great course, online anesthesia mega course. My name is Ahmed Abbas, and I work as anesthetic registrar in Temple Street Children University Hospital. Registrar anesthetist with a special interest in pain. I had 1 year of training in pain medicine in Cork University Hospital last year, and I finished my Irish diploma of pain medicine. So today I'm going to be your moderator through this course. Today we will have 2 lectures. First lecture will be with Dr. Ahmed Kafafy, and it's about the pain mechanism and some hints about the pain medicine and its relation to the pain pathway. And the other lecture will be about the local anesthetic toxicity. So we will start with the first presentation with Dr. Ahmed Kafafy. Just a brief introduction about Dr. Kafafy. He was graduated 2000 from University of Alexandria, and he was awarded MD and master degree in pain medicine. Then he moved to the UK. He had fellowship of pain medicine from the faculty of or from the Royal College of Anesthesia. He has been working in UK for 13 years, 8 years out of this as a consultant in pain medicine. So he's currently being consultant and the clinical service lead for pain musculoskeletal department at Royal Orthopaedic Hospital, Birmingham, UK. And before starting this session, as you may have heard from Dr. Saad Mahdi, Dr. Ahmed promised to give us brief hint about the registration in the UK as a pain specialist or pain consultant. Actually, everybody to practice pain in UK, he should have a specialist registration in anesthesia first, then pain medicine as special interest. But he has a good experience about or regarding his registration in General Medical Council as pain specialist only, and he promised to give us a good hint about it. So welcome, Dr. Kafafy.
Thank you, Dr. Ahmed.
I'm looking forward to hear your presentation today.
Thank you for your very pleasant and nice presentation. Thank you very much. And I would ask you a favor during this lecture, please, because I'm very old-fashioned, so I find it difficult to keep an eye on the time at the same time. So if you can let me know, halfway through and maybe 5 or 10 minutes.
Yeah, absolutely. I will let you know.
Thank you very much. Welcome, everyone.
So
good evening.
Go ahead, please. Yeah.
Good evening, everyone, and I hope you're well and safe with your families in these difficult times. As Dr. Abbas presented, we're going to speak about, first of all, I want to thank all the people who invited me here, the committee of the Mega Online Academy. These people are really doing a great job. I come and do the lecture, in half an hour, 45 minutes and go, but these behind the scenes, there is lots of very hard work and training for everyone in order to bring these lectures out. They choose people, they choose the topics. They're trying to bring everything. They take time out of their jobs and their families for this. So we all wish them, that God bless them and their families. I'm going to very briefly speak about the training in pain medicine in the United Kingdom. It's very difficult because I need a separate lecture to speak about it in details. I'm going to speak very briefly, and please, after I finish, you can ask questions about the topic I will speak about today, and you can also ask questions about the training in pain if you're interested, because I assume most of the people listening to us now are outside the UK. I've been in the UK for 13 years. The first 5 years, I've always done pain since the time I came to the UK. I came mainly to do research in pain because that's what was my area of interest in 2007 when I came. So I worked in clinical fellow jobs, training jobs, but out of the training number. So I didn't have a training number. I was outside the module of the training, but I worked 5 years and I gained lots of experience during these 5 years all around the country. And then after that, for the last 8 years, I've been a consultant. If you're interested in pain medicine and you want to be a pain medicine in the UK, there are different pathways. The easiest way, or not the easiest, I would say the commonest way, or the popular way that most people pass through is through anesthetics. Pain is not a specialty. Pain is a subspecialty. It comes under anesthetics and it also comes under neurology. But if you look at the pain consultants in the UK, 90% or 95, up to 95% of them are anesthetists. So they go through the anesthetic training, which is 7 years. And then the last year of anesthetic training, you can do 1 year of advanced pain training. And during this advanced pain training year, which is the 7th year of training, you can do you have to do now 2 exams with the Faculty of Pain Medicine, which is part of the Royal College of Anesthetics. A primary exam and a final exam. It's not a very difficult exam. You just got some modules about psychology and about rheumatology, so it contains many aspects that it relates to chronic pain. That's one way and the easiest way. The other way is to go through anesthetics as normal. So that's the first way, sorry. The second way is to do a Caesar, and that's what I've done. So I don't know if you know the expression Caesar. Caesar means Certificate of Equivalence of Specialist Training. So if you're not a trainee in the UK and you came from abroad, you have to prove that you have equivalent knowledge and skills in order to be put on the specialist register. There's something on the General Medical Council called the specialist register. You have to be put on this in order to work as a substantive consultant in the UK. So this route, you have to do pain jobs as I've done. And you have to prove, you have to have lots of competencies, lots of paperwork to sign from the areas that you work. And then you apply after that for Caesar. But the thing about the pain medicine, because it's a subspecialty, in order to apply for a Caesar, you have to prove that you have also basic and intermediate anesthetic skills. So you have to have a very high qualification in anesthesia. For me, I didn't have the FRCA, like most people have in the UK, but I had my MD from Egypt, which is equivalent to the FRCA. So you can ask questions about this at the end. You can open the GMC website and then type Caesar, CESR, subspecialty Caesar specifically if you want pain medicine only, and you'll find plenty of information. And please feel free to ask me at the end if you need it. The lecture today has a bit of a strange name, if you can see that. Why does it hurt? You're not going to find many lectures that starts with a question mark and a question at the beginning. The reason of that is I was asked to do this lectures for anesthetic trainees. So if you're a pain consultant, the information I'm going to say now, maybe it's going to be a refresher for you, but it's going to be easy. But this is very important, what I would say today, for anesthetic trainees who are setting exams or fellowship postgraduate exams, and to help them with the pain module. Because in order to pass an exam of anesthetics only in the UK, you have to do a module in pain as well. So this lecture will help in terms of the pathway, mechanism, and relation to some medicine that we use on a daily basis. I was asked to do it specifically for people who entered the exam, and I had very good positive feedback over the last couple of years. I always change a bit every year when new drugs come up, so I keep changing it, and I deliver it at least 3 or 4 times a year to trainees. Virtual communication probably is going to be the way through in the future. So hopefully I have another few lectures coming in the next few weeks as well that will be important for exams and fellowship. Why does it hurt means why do we feel pain? What's the reason that we feel the pain? What's the mechanism of this? Does it really matter? Is it important when you feel the pain to know the reason you're feeling this? Absolutely. If you don't know the pain, you won't be able to know what drug to give. Because there's different types of pain. There is a burning pain. There is a dull aching pain. There is a shooting pain. Every pain has got a different reason and a different pathway. So the drug that we need to use, how does the drug work in your body depends on the mechanism and the pathway of pain. The side effects, every drug has a side effect. And you will see in the following slide how the side effects is all related to the pain pathways and the mechanism. If you want to invent a new drug in the future to treat pain, you need to know how do we feel pain exactly. You need to know it in most details. New interventions, all these new, have you heard of neuromodulation? Neuromodulation is something like spinal cord stimulator. That's one of the types. And these are devices that inserted, it's a very invasive procedure. You put a device near the spinothalamic tract to continuously stimulate the spinal cord and reduce pain. If we don't know that there is a mechanism of this spinothalamic tract in producing pain, how will we invent these new treatments? It's very important. This definition, I'm sure you know about, but it's very important. If you're asked about this in the exam, what's the pain definition? The IASP. IASP is an international association of study of pain. It's in the United States. It's very important to look at the website of the IASP. There is very, very useful material on there, very useful review articles about many, many aspects of it. Very important for us when we entered the exam many years ago to go through this website, IST, okay? So pain is an unpleasant sensory. We know that it's a sensory problem. Recently, we knew that there is lots of emotional experience, especially in chronic pain. And when you say actual or potential tissue damage, what does that mean? Actual tissue damage means a trauma, an injury. We know that, we can see it, we can feel it. But what about people who have pain and we couldn't find the damage? So there is an obscured damage. There is a damage that is potential, that we can't see it in front of us. An example of that, which is something that is very common in everywhere, 70% of the UK population feels back pain or get chronic back pain at some degree in their life. Can you imagine how common is that? You don't see a damage in there. The patients come to the clinic and say, "Doctor, why am I feeling pain? There's nothing in my back. The MRI is normal. It's in the muscle. It's hidden in the muscle, or the joints, or the ligaments." Could it be useful? That's a very important question. Can pain be a useful thing? Absolutely. I will tell you now, I will give you some very interesting examples about people who are not feeling pain. They can hardly survive. They will die. Because pain isn't alert. Remember that? If someone gets a heart attack and he doesn't feel the pain, he will die without having any treatment, because the pain is the alert. It's the warning sign that you need to do something about it. I'll give you two examples of that. There's a very famous lady, her name is Misty. I don't know if you heard of her. She's Canadian. She lived in Canada many years ago. She was very intelligent. She studied at Montreal in McGill University, one of the most famous universities in the world. Her dad was a consultant doctor. This girl was born without feeling anything. And at this time, they didn't know what was the problem. She couldn't feel anything. She burned herself every day. She used to break her bone every day without feeling anything. Her dad tried to protect her as much as he can, but she died at the age of 29 years old after all the protection. Do you know how she died? She died from septic arthritis. She died from septicemia, from an infection in her joint. If you can look at my finger now, if I bend my finger back as much as I can, what will stop me from doing it? It's actually the pain. If I don't feel pain and I'm sleeping at night, I will break my finger when I just move in bed. So pain is very important. Without pain, people can die. A Pakistani 10-year-old boy who worked as a street performer, he didn't feel pain. He had a mutation in one of his genes that is responsible for opening the sodium channel. That was recently. He used to perform in the street and gain a lot of money. Walk and call, bring knives and insert it in his arms, jump off buildings. He died before his birthday at the age of 14 when he jumped off a roof because he wasn't feeling pain. Does that mean that there is no one living with this specific gene mutation? No, there is. There is a lady, if you Google her, her name is Mrs. Jo Cameron. She's now 70 years old. She doesn't have any pain. This lady, bless her, she works with Cambridge and Oxford University, and because of this lady, they have managed to invent many new drugs as painkillers, especially the recent drugs that work for rheumatoid arthritis, sodium channel blockers, and all of these. Let's go through the mechanism quickly now. I mean, we're going to go, we don't have to go, we can't go in details because of the time. So if you look at this, this is going to be repeated many times throughout my lecture. If you look at this hand, we start by a noxious stimulus, a painful stimulus. Noxious means unpleasant. When you pinprick your finger, what happens? The primary afferent neuron passes from, that stimulates first a pain receptor. A receptor is a protein, and the pain receptor is called nociceptor. And this primary afferent neuron passes through two different fibers, A delta and C fiber. And they go all the way, as you can see, to the dorsal root ganglia, and then they pass to the dorsal horn of the spinal cord. That's the primary afferent neuron. We probably all know it. And then it decussates to the other side, to the white matter, and then extends through the spinothalamic tract, all the way to the thalamus in the brain. And then the third order neuron passes from the thalamus to the cortex. And this is where the pain gets perceptive. This is what we call, this is the pain perception. So you don't feel the pain until it passes through all of that. It takes parts of a milli of a microsecond, very quick. But you will not feel the pain unless it goes all the way up. So if we can try and ease it a little bit, we'll describe it as a trip, this pathway. You start it from home. Hopefully, let's hope that this lockdown goes away and we can all go on a holiday or go to the beach or something. We start from your home, the trip, and it ends at the beach. Yeah. So that's transduction, that's the start, and that's what happens at the periphery. The injury, the release of the neuromodulators, the inflammatory mediators, and then the primary afferent transmits to the spinal cord. This is called transmission. And then after that, from the spinal cord up to the brain, and until we call it perception. The last one is very important. It's altered on the way. During your trip, many things happen to you, good and bad. The good things are the things that make this pain better and reduce the intensity of the pain. The bad things that happen, that excitatory neurotransmitter make this pain worse. And this is what we call modulation. That word neuromodulation. On the trip from the periphery to the brain, how can we modulate what's happening to make this pain better? As I told you, this diagram is going to be repeated a lot. Transduction, transmission, modulation, and perception. Remember these expressions because we're going to talk about them in detail. This definition is quite important because sensation of pain is a result of peripheral and central sensitization. It's a balance between excitatory and inhibitory function at different levels. What does that mean? The sensation of pain is like a fight. You know, if two people fighting and one is win, but one is the good and one is the bad. The good is the inhibitory and the bad is the excitatory. The good is the one that is trying to make you not feel the pain, and the bad is the one that is trying to make this pain as severe as possible. So it's the fight. If the excitatory wins, you're going to have chronic pain, and that's what happens. And if the inhibitory wins, which happens in most of the time, especially in acute pain, when you have a small injury or something, you feel the pain for the first few hours, maybe a couple of days, and it goes away because the inhibitory supercell. What do we need to know? These are the titles I'm going to speak about: nociceptors and primary afferent fibers. What happens at the dorsal horn, which is the most important site during the pain journey? Ascending tracts in the spinal cord, pain processing in the brain, inhibition of pain, gate theory, and the importance of the gate theory. We need to know about it. Visceral and neuropathic pain. Why does the pain become chronic? Central sensitization. There's a lot of things, but we'll go through it quickly because of the time, unfortunately. But please go back to this lecture and stop at each slide because there will be some very important slides coming. What do we need to know? Nociception. Okay, let's speak about nociception quickly. Nociception means what happens in the period of transduction, the early peripheral period. Nociceptors, we said, are the receptors at the level of the periphery or the organs. Where does these nociceptors exist? Everywhere in the body, apart from a few places which I'll tell you about. So we are created, so our God created us, that every organ that needs protection will have nociceptors to protect it, because that's the way you will feel the pain. What's the biggest organ in our body? It's our skin, because the skin is everywhere. Can you imagine the scientists found that every 1 centimeter square of skin has got 200 pain receptors? Can you imagine that? Are there any places in the body that has no nociceptors? Don't feel pain? Yes. The brain is one of them. You probably anesthetist, you know about awake craniotomy. You can open someone's brain and you can operate on them without them feeling anything. There will be sympathetic response, but there might not be pain. So these are the nociceptors. And stimulation happens at this stage, passes, as you said, through the A delta and C fibers, and goes all the way through the primary afferent neuron, as we said. We're going to go quickly through this. You probably know about this. A alpha and A beta, not much concerned about alpha. It's a proprioception. It's a sensation of position. That's how you feel that you're standing up on grass or on a street or on asphalt or something like this by this A alpha. A beta is important. It will be involved in the gate control theory we will mention. A delta and C fibers are the most important, and they're the slowest and the smallest in diameter as well. A delta is myelinated, C is non-myelinated. You need to remember that. Inflammatory mediators that happen at the level of the peripheral injury. What happens there? The tissue gets damaged, release of inflammatory mediators, and we all know about it, prostaglandin, serotonin. What happens at this level? They start stimulating an action potential. We know about that. Sodium channel. They change a stimulus, which could be mechanical, chemical, thermal, like heat or cold, to an electric impulse. So they have to change it to an electric. So it's through sodium channels. Sodium channels are so important. Action potential happens. This signal passes through the primary afferent to the dorsal horn of the spinal cord. Okay, and there's something that happens called primary sensitization or peripheral sensitization. You notice that if someone is injured at the level of the skin, the area around the injury is painful as well, because it reduces the threshold of stimulation around it because of the trauma. Now we mention some medicine. Non-steroidal anti-inflammatory drugs, they work exactly at this level, at the level of transduction, the level of the periphery. Because the way they work is, we all know about that, cyclooxygenase, they block this enzyme, which changes the arachidonic acid to prostaglandins. Prostaglandins are one of the most important inflammatory mediators that cause pain and fever. That's why if you block that with non-steroidal, it stops the production of prostaglandin and it reduces pain and inflammation. We're not going to go in more detail. Versatis, I'm not sure if this is available in countries. It's a very, very useful drug. It comes in the form of a patch. It's a lidocaine. You all know how lidocaine works. It's a sodium channel blocker. This Versatis has been licensed in the UK to be used for patients who've got post-herpetic neuralgia, shingles, yeah? So it's a very, very useful drug. Got 5% lidocaine. You stick it on, you leave it for 12 hours on the skin, and it helps a lot with symptoms of allodynia. You know what allodynia is, which is hypersensitivity to touch. Qutenza is a recently drug that was produced in the UK. It's a very, very useful drug. I'm sure you know all about capsaicin. The capsaicin works mainly on the substance P, which is one of the excitatory neurotransmitters we're going to mention. Capsaicin comes in the form of a cream, which is 0.025%, very low concentration. They invented this patch. It's 8%, very, very painful. If you put it on the skin, it feels a lot of burning. We have to put some ice packs before. As you can see on this picture, it's very useful for amputees and phantom pain and stump pain. You put it on, you leave it for 3 hours. Many people get off their gabapentin, pregabalin, amitriptyline, and they have this patch for every 3 or 4 months. Not a cure, it's just a painkiller. Licensed to be used for peripheral diabetic neuropathy, HIV neuropathy, and as I said, post-herpetic neuralgia as well, like the Versatis patch called Qutenza. Very important to know about this as well. Again, this picture, I'm getting A beta fibers, if you can notice, it's the touch. The A delta and the C fibers are mostly the pain. And why do we mention the A beta fibers? You will know now. Okay, spinal cord dorsal horn, that's the most important in the pain pathway. A delta and C fibers, they go all the way to the dorsal horn of the spinal cord, and that's called the primary afferent, and they terminate there. And at this stage, you will find both excitatory and neurotransmitters such as glutamate and substance P. So this is the bad guys, they make the pain worse. And you will also find inhibitory neurotransmitters like glycine and GABA, which are the good guys. Then there's an interaction that happens at this level, and then the secondary order neuron goes up. The next slide is very important, and it looks very confusing, but believe me, it's one of the easiest slides that can make you understand this topic. Please go down to the lower picture first and look at this. You will find a purple or a violet line coming from the right-hand side if you're looking at the picture, and that's the primary afferent fiber. Yeah, that's the one that is coming from the periphery and the tissues. And it goes and relays in the dorsal horn of the spinal cord, as you can see, and then that orange secondary order neuron comes out, decassate to the other side, and goes up to the brain. What about this nice blue line that is coming down from the brain? This is called the descending neuron. Put in your mind always that 90% or more of the descending neurons are inhibitory, so they are very good. We want more of these. Yeah. If we take a square over this and magnify it, then you look at the upper picture, please. If you look at the side and look at these small circles, substance P or glutamate, you can see these. These are one of the bad neurotransmitters. They come down from that primary afferent, so they come all the way from the skin, and they make the pain a lot worse. They stimulate the receptors to excitate the painful pathway. And then if you look beside it about the red, the GABA, that's one of the nice ones. Glycine, the black, is one of the nice ones. You'll find the GABA present at the primary afferent, and it's also, can you see this nice green arm on the right side? This is an interneuron, and all interneurons are mostly inhibitory as well, as you can see. The pink is opioid neurotransmitters and receptors that are released normally in the body. Look at the left side, the descending neuron, and this is the descending inhibitory neuron. Look at the neurotransmitters that comes with. Opioids is the pink, serotonin, the blue, norepinephrine. Okay, so these all inhibit pain. These are the good guys. We want more of these. Yeah. One of the bad ones as well is an NMDA channel, which is stimulated by glutamate as well, which is the stimulatory one. And we're going to go through some drugs again that work at this level. Tricyclic antidepressants, amitriptyline, we all know it. It's got the best evidence in helping patients with neuropathic pain. How does this work? We did say that neurotransmitters make a huge difference at this level. Serotonin and norepinephrine. Do you remember what did you say about these? They are an inhibitory neurotransmitters that come down from the brain. These inhibit pain. I want more of these. How can I get more of these? By amitriptyline. How does it work? It stops the reuptake of them, blocks the reuptake of noradrenaline and serotonin. So it makes more of it at the level of the synapse, the neurotransmission. So it makes the pain a lot better. It blocks hyperalgesia. It blocks the sodium channel. It works exactly like a local anesthetic as well. Anticonvulsants like gabapentin and pregabalin work at this level as well, at the presynaptic level, so the pre the synapse. You remember the GABA, which gabapentin comes from the GABA. GABA is an inhibitory neurotransmitter. It also decreases the excitatory neurotransmitters, the bad ones like glutamate and substance P. That's why it works very well at this level for nerve pain. NMDA is a very important receptor. An antagonist of it, like ketamine, you know ketamine, we all use in anesthetics, and methadone. They block the NMDA receptor, which is a really bad receptor. One of the reasons of making the pain chronic, they found the NMDA receptors. The ascending tracts in the spinal cord. So we finished the dorsal horn. I know I went through it very quickly, but please go back and read this slide again because it's very important. Ascending tracts in the spinal cord, there are two tracts, spinothalamic and spinoreticular. So now we finished at the spinal cord, decussation to the ventral lobe, and then it's going to go all the way up to the brain. We've got two ways. Spinothalamic, that's a secondary afferent neuron, and that's mainly responsible for localizing and feeling pain, yeah? And it sends some receptors on the way in the medulla, so a very important place. Can you see this PAG, periaqueductal grade? That's very important, remember that. So that's the spinothalamic tract, and it goes all the way up to the thalamus, then to the cortex. The spinoreticular, and that's when they discovered that, they then changed the definition of the pain that we mentioned at the beginning. The pain has got an emotional issue as well. That's a different way. It's called the spinoreticular, where it goes to an area of the brain called reticular formation. Look at this picture. So the spinoreticular is the green, and it goes all the way up to the thalamus and the cortex, and that's responsible for the emotional part of the pain, the spinoreticular. The spinothalamic, as we said, the pain intensity and the localization. Pain processing in the brain. That's the end stage where we start feeling the pain. The experience of pain is very complex, as we said. It's affected by cognition, such as distraction and catastrophizing. We need to stop a bit at this bit. So pain is not only a damage to the tissue. There is many other components that affect pain. You know what distraction is? The pain, I'll give you an example of someone comes to your clinic and say, doctor, I feel very bad pain in my knees. He's got arthritis in his knees, and he feels severe pain at night time, specifically. You know, because he's focusing more on his pain at night time. But what about, we asked him, what about you at work? He said, I don't feel it. I hardly feel it at work because he's distracted. And that's one of the mechanisms of mindfulness, CBT. You know, all psychological interventions work by this way. Catastrophizing, what does that mean? That's a very important expression of people who have chronic pain or suffer from chronic pain. Because catastrophizing means exaggerating. So they think that when they move, they're going to damage, they're going to cause damage. So that's all about belief. So the patient comes to you and said, doctor, I don't want to move because when I move, I feel pain. And I tell him, okay, that's fine. Why don't you move then? Because he said, I'm going to damage my back. So he's got thoughts in his mind that because he's feeling pain, he's causing damage. When you show him his scan and explain to him that he doesn't have much and that the movement will make him better, you'll find that his pain improves a lot. So cognitive behavioral therapy is one of the most important therapies in chronic pain, and also mindfulness, which we can speak about this in a different lecture. Pain matrix, you need to know about this expression, which is very important. They did lots of functional MRI scans to see how the brain behaves when you're feeling pain, and they find amazing things. Just put the pain matrix and search for this, and you'll find very interesting subjects about what changes they found happening under MRI when the people feel pain, and will also their emotions change. Common areas of pain perception. I'm not going to go through in details of this because we haven't got much time. Inhibition of pain transmission. That's something very important. You want to make the pain better. How can you do that and at what level? The most important, that's the natural inhibition that happens in our body without any medicine. There is something called gate control therapy that happens at the spinal cord level, and there is a descending inhibition that comes from higher centers. If you remember the blue, you remember the nice blue line that comes down from the brain? That's the descending inhibitory modulation from the PEG and the RVM, which are very important areas of the brain. What's gate control theory? Very interesting theory discovered in the 60s. Can you imagine that? It's still one of the most important things that happened in the last century, the discovery. If you remember the A beta fiber that we said we're going to come back to it, why sometimes when you bang your head and you start rubbing it, you start feeling that the pain gets better. How does this happen? This happens by a very interesting mechanism, and that was proved. C fibers stimulate the interneurons at the dorsal root ganglia and release excitatory neurotransmitters. Yeah, we agree on that, especially substance P, which is released by the C fibers. And then when you start rubbing, you stimulate a completely different fibers called A beta fibers. The A beta fibers go to the same area of the dorsal root ganglia, but they put massive amount of inhibitory interneurons to inhibit what's happening at the dorsal root. I hope that makes sense that quick. Descending inhibitory modulation, as we said, comes from the PAG and the RST. These are very important areas in the brain because they send down inhibitory neurotransmitters. If you look at this picture, the red and the green, the red is the ascending pathway. Yeah, and that goes all the way, as we said, to the hypothalamus, and it goes to the somatosensory cortex. And then once that happens, then the body starts to inhibit this stimulus to reduce this pain. And how this has happened? By releasing inhibitory neurotransmitters. And the descending pathways goes down. It starts in the cortex and it goes down through the PAG, which is the periaqueductal gray, as you can see that in the middle, in the midbrain, and then it passes through a very important area as well. It's called the RVM, sorry. And then it goes back to the dorsal root of the spinal cord, as you can remember. This green was blue in the previous, sorry, I'm confusing you now. This green was a blue line in my previous slide. So it goes down to this level and it releases, if you remember, serotonin, norepinephrine, and the most importantly, what does it release? Opioids. We've got natural opioids in our body, which is very important. It releases that. And you know, the descending inhibitory pathway also responds to relaxation and exercise. So if you go out for a walk, some people come to you from clinic and say, I've got severe back pain, doctor, when I'm sitting. But when I go out and walk in the park a bit, it feels better. Because exercise has proven to stimulate this inhibitory pathway, this descending inhibitory pathway. It increases endorphin, morphine in our body. Very quickly going to go through visceral pain. That probably needs a different lecture. So visceral pain is different. It arises from organs inside our body, innervated mainly by C fibers. It's diffuse, it's deep, it's associated always with autonomic change. So anyone who's got visceral pain, got problems with his bladder, anyone who's got cancer that is pressing on organs, it causes nausea, vomiting, changing heart rate, all of these are autonomic changes. It evokes very strong emotional responses. Studies show that people who've got visceral pain are more depressed and anxious than people who've got musculoskeletal pain, and these are studies show that. In contrast to somatic pain, it feels like a burning or a crushing pain, yeah, and it's mainly because of the distension or the stretching of these organs. And then this stretching reduces the blood supply to the organ, so it causes ischemia, and then after that it results in necrosis and irritation of chemicals. This is very important as well to know about the third pain. The third pain is pain that is felt at a different place from the injury completely. Like someone who's got had a gallbladder surgery with a throat laparoscopy, and he diaphragmatic irritation, and he starts feeling pain in his shoulder. Why is that happening? Because or someone who's got a heart attack, and then he starts feeling pain in his back or his shoulder as well. Because both afferents pass through the same pathway and go to the same area of the dorsal root ganglion. So the relay, the central mechanism is the same, although the peripheral comes from two different areas. And this is a diagram, very useful diagram. You can go back to it about most areas of the third pain, which is important for us to know. We all know about neuropathic pain, damaging that happens to the nerve, and many things can result in neuropathic pain, and there are many different types. My next lecture, I'm going to speak about management of neuropathic pain and the drugs used in it. So I'm not going to go in details today. So next week, hopefully, we're going to go in more details about this. CRPS, more details also next week, which is complex regional pain syndrome. We're going to explain the mechanism of this. It comes under a word of stamp, so there are sensory changes, trophic, autonomic, motor, and pain. No one actually knows the exact mechanism of CRPS. It's a very bad disease that it's very difficult to treat because there is extreme hypersensitivity that is usually not related to the degree of energy. That's CRP. So something else very important is to know, why does the pain become chronic? So chronic pain is there's something called plasticity that happens. And plasticity means chronicity, or changes in the structure in the brain that makes this pain chronic. So peripheral nociceptors become strongly sensitized to circulating or hormones. So they become more sensitive to inflammatory mediators. That process many years ago used to call wind up. So it's like an electric wire that becomes stimulated. Now they call it central sensitization, which is one of the mechanisms of chronic pain. Peripheral sensitization, they explained that before, which happens at the level of the periphery, and it's as a result of the injury. So it reduces the threshold of the pain in response to the mediators, the inflammatory mediators that are released. Yeah, central sensitization happens high up. Very interesting, this central sensitization, because this is what the cause of allodynia is. Sometimes a patient with chronic pain or CRPS, when you touch them, they start jumping of pain. So, but you know that the touch doesn't stimulate A delta and C fibers. So why are they feeling pain? Because you now change, plasticity happens, changes at the level of the A beta fibers. So the A beta fibers became nociceptive fibers. Can you imagine that? They used to be mechanoreceptors, touch only, but now they became nociceptors. Complete changes that happened in chronic pain. Very little we know about this. I'm nearly finished. So pain starts by nociception. This is an important slide. Feeling the pain, start by feeling it. And then after that, what happens?
We don't want you to finish. We want you to continue.
Oh, really? Thank you, Dr. Ahmed. So hopefully we're going to get some questions and maybe have some more discussion. So nociception is at the level of the receptors, as we said, at the periphery. And that's the first thing that happens in pain. And then after that, you start feeling the pain, as we saw about the pathway. And then what happens after that? How does it become chronic? How does it become a major problem? And then it starts affecting your attitudes and beliefs. Some people leave the work. Some people stay at home. Some people stop speaking to others because they're really depressed. They've been having pain for a long time. So their beliefs about their body, their attitudes towards others change. And then after that, they become depressed. They can become anxious. It starts affecting them psychologically. And it can make a huge burden on them and their families. So the pain is not only, unfortunately, some people think that the pain is only a physical problem. It's only what's happening at the level of the back of the knee. It's a very bigger figure. It's a very bigger picture. Pain behavior after that change. They start attaining something, as we said, catastrophizing is one of them. They start exaggerating. There's something called avoidance. They start avoiding other people, avoiding to walk in a bending position all the time. And then it starts affecting people around them in social environment. That's why pain is a biopsychosocial problem. It's not only biological, psychological, or social. It's the mixture of all of these. So please, if you can go back to this slide and read what's written under that, because it can be very useful. I've just taken, that's the last slide. I've just taken a screenshot of one of the books, very interesting books. It's by a guy called Yu Sun. He's from Hong Kong. And then we used to study that. It was part of the curriculum for the fellowship. And I like this bit because it helped me a lot in clinic. So when you see a patient in clinic, for example, you want to take history of the patient. You want to fully assess and examine the patient. And then also you review everything about the patient biologically. What's the underlying treatable condition? That's the first thing you look for. Is there any problem on the MRI scan? Can I treat something? And then you can go through this route, but at the same time, never, ever leave the psychological bit. You have to have very good psychological assessment. This is part of the pain exam in the UK, that you have to learn how to psychologically assess a chronic pain patient. Does he have an anxiety, depression? How can I treat that? How can I help him? You need to explain in details his problem. You need to ask him about his family, his work. Is there any litigation? That's very important. Some people come to you, they don't want you to cure their pain because they're getting money of the pain. They've had a whiplash injury in the neck. The insurance company is there, is going to bring him a compensation. You ask him, oh, you need an injection. I can do an injection and help you back. Oh, doctor, I don't need an injection. I will be okay. And you can see lots of problems in MRI scan, but he's going to get money from this. So you have to cover all the aspects of pain. You have to look at his paddles and daddles. That's a very important thing. Paddles are personal activities of daily living. What is the pain stopping him from doing? Is he able to dress himself? Is he able to walk? Is he able to look after himself? Because you're going to put a management plan for him. We very rarely cure patients with chronic pain. Very rarely. I'll be honest with you. No cure. for chronic pain. If the pain exists beyond 2 or 3 years, we can't cure it, but we can manage it. We can teach the patient how to live a good life with his pain by teaching him. There is something in the UK called pain management program, which runs over a period of 6 to 8 weeks. Maybe we can do a lecture about that in the future. They're very useful. It changes people's mentality and their thinking of the pain. And then they can live a happy life, although the pain doesn't go away. And we reduce the medication to the minimum as well. So I know I was very quick and I can take more time of that, but we haven't got much time. So the conclusion is pain is a sensory and emotional experience. You should focus on both, as we mentioned. There's fears and anxiety and lots of things that are involved. Pain transmission is a complex peripheral and central process. We did mention this briefly. I hope the message you received. Please ask questions if you didn't understand anything about the pathway. There is lots of modulation, as we said. The most important part is the modulation. How can we change this pathway on the way? Do you remember when we said it's a trip? How can we alter this trip? We don't want this to reach the destination, to the brain. We need to cut it in the middle by doing some modulation. Current areas of interest in pain research, investigating the effect of mood. There's lots of research going in the UK about this at the moment. Thank you very much.
Thank you very much. Thank you very much, Dr. Kafafy. This lecture was really, really very nice, comprehensive. And you did a lot of effort in preparation of this, I think. And I also like your introduction about the importance of pain as a protective mechanism of the body. And I like your imagination about the battle in the spinal cord between the bad and good guys. I personally have lots of questions for you, but we have a lot of questions here from the audience. And we are actually running out of time. So we'll try to take some of it. So first question here I got from Anhar Fathi. She's asking, is there a role of steroid injection with local anesthetic or with any opiates in the treatment of pain?
That's a very good question. So role of local anesthetics and opiates. If you remember what we mentioned in the lectures, for example, when I started speaking about the periphery, you remember the injury of the tissue. At this level, the opioids work at this level. So if you give the patient morphine, if you give the patient drugs like partial agonist safe opioids like buprenorphine, they work at the periphery because there are opioid receptors in the periphery, but they also work centrally at the dorsal root ganglia, the DRG, and also at the level of the dorsal horn, the opioid. Local anesthetics are sodium channel blockers. They are one of the most effective painkillers. That's why we use an anesthetic. We do a regional block. You do a block and the patient feels no pain. But unfortunately, they haven't invented a local anesthetic that can work more than a few hours or maybe a day. They haven't. There is a drug called mexilatine in the UK that has proved to be complete failure because it's got lots of side effects. But the research is working now on local anesthetic sodium channel blockers that can be used for chronic pain. So yes, there is a role, but I wouldn't advise you to start chronic non-cancer pain patients on opioids because there is an opioid crisis in the whole world at the moment. They found that opioids on the long term, they cause lots of side effects, especially on the immune system and the endocrine system. The safest opioid that you can use is partial agonists, such as buprenorphine. And I'm sure this drug is available in many countries. I hope that answers the question.
Yeah, I got a question here from Prof. Yasser Zaghlouli. He's asking, what do you think about the opioid-free analgesia?
Opioid-free analgesia. So do you mean for patients with chronic pain, probably? That's very. If you can keep a patient off opioids, that would be brilliant. You know, because we know of the long-term tolerance. It's not only about addiction, because many people think about addiction, but tolerance and dependence, and also the long-term immunological, hormonal, the effects on the bone. The research found, the studies found that the opioids cause severe osteoporosis after a long time, and also opioid-induced hyperalgesia, which is a theory, but I've seen many patients in clinic over the last years with severe pain as a result of opioids. And once you stop them, their pain gets better. So yes, an opioid-free analgesia regime for chronic pain would be definitely advised if possible.
Thank you very much. And I have a question myself. You spoke about catastrophization, and you know it's really very difficult in assessing the chronic pain patient. Usually they are desperate patients. They are suffering lots with their pain. Sometimes they can't sleep, they can't work. And there is, from my point of view, there is difficulty in recognizing the psychological aspect of the patient or of the pain, and to recognize which patient is in agony and having hard time with his pain from the patient who is catastrophizing or malingering.
Yes.
As I know, there is some pain scores which was designed to recognize this psychological and behavioral aspect of the pain, like the brief pain inventory. What do you think of these scores, and how you yourself can recognize the patient who is genuine from pain point of view and the patient who is either catastrophizing or malingering, you know, for some kind of compensation or financial things, you know?
Thank you, Dr. Abbas, for this question, because I wanted to mention this during the lecture, but I completely forgot about this specifically, because I know that in my own country, unfortunately in Egypt, there is nothing as MDT. I know that, you know, professors like Dr. Makharita and Dr. Khalid Abdul Hamid, they are starting to get that, but it's not something common. New pain patients has to be seen in a multidisciplinary clinic. You can't see a new patient as a pain consultant on your own. You need a clinical psychologist sitting with you in the room. You need a physiotherapist, at least. Some places also have an occupational therapist. And this, you only need 1 hour. That's what we provide. New consultation is 1 hour with the patient, and that covers everything because we have an approach to that. As you said, there are some very good validated questionnaires. We, in our clinic at the Royal Orthopedic Hospital, we send these questionnaires with the invitation letter to the appointment to the patient. If they don't fill it, they don't get an appointment. One of them is called the HAD score. The HAD score is very useful because it can detect the degree of anxiety and depression of the patient. And as you do, the BPI, or the bridge pain inventory, is good as well. But you need to cover the following before the patient comes to you. You need a questionnaire about pain. You need to do the pain score, VAS score, NRS score. What's your pain out of 10? That will tell you something. BPI, there is a brief one. There's one called the brief BPI. That's very good. Pain inventory. That's good. And if you use also one like the HAD, or there's someone called the AQD5T5. This is also functional because you want to know how is the patient functioning. Does he go to work? Is he staying at home? Does he sleep well at night? You need to know these things. They fill these questionnaires. They come. They're assessed by 3 people: me, a psychologist, and a physio. And then we put a full management plan for this patient. I would tell you, Dr. Abbas, before we had this at our hospital, I started this at my hospital in 2016 when I became a service lead. Before that, the outcome for our patient was completely different from our outcomes now in terms of patient satisfaction, improvement in pain, improvement in their lifestyle, everything. MDT in pain clinics is crucial.
That's interesting, and we also have a lot of questions here. I don't think we got time to answer all these questions. So I think also we may arrange another session for you to talk about the registration in the General Medical Council again. I really will like Dr. Saad to consider that, because we got a lot of questions about the registration as well. So
I can only advise on pain. I can only advise mainly on pain.
Yeah, this is what I mean. The registration with the GMC, specialist registration as a pain consultant. So I will just grab the last question, then we will move on to the next presentation. So it's regarding the capsaicin cream. You can prescribe it for the patient as an outpatient cream, or it needs to be applied in controlled session by a specialized nurse. What do you think about that?
Okay, a capsaicin cream in the UK is on prescription. When I mentioned capsaicin in my lecture, I didn't say the cream. I was speaking about the patch, which is different. Capsaicin cream is very low concentration of the medicine in it. The Qutenza patch that I mentioned has got 8% in it. The cream in many countries, including many European countries, can be get over the counter. So you can go to the pharmacy and buy it. There's 2 strengths of it, 0.025% and 0.075%. In the UK, unfortunately, it has to be a GP or a pain consultant that prescribe it. My advice before prescribing capsaicin, don't give it for back pain. Don't give it for any musculoskeletal pain. It only works for peripheral neuropathic pain. If someone have a peripheral nerve injury, and they has to have symptoms of allodynia and hyperalgesia, hypersensitivity in this case. It works very well in this case.
Thank you very much, Dr. Kafafy. This was interesting, really, and we hope we will see you again in another lecture in this anesthesia mega course series. I would appreciate if you will stay with us, and if you will try to answer some of these questions sent by the audience, either by typing or whatever you will find appropriate.